Welcome everyone to Social Medicine Grand Rounds, co-sponsored by the Health, Equity, and Translational Social Science Research Theme and the Leo Rangel Professorial Endowment. Our speaker today is Alex Barnard, who's joining us from NYU, where he's the Assistant Professor of Sociology. And he studies decision-making in mental health care systems. I think that should be of interest to all of us. Alex is working on two book projects. The first is called Mental States, Ordering Psychiatric Disorder in France and the United States, seeks to understand why people with similar conditions experience different trajectories between institutions of care and control in France and the US. The second project, Gravely Disabled, Coercion, Compassion, and Conservatorship in California, examines involuntary treatment here in California. He presented a talk based on this second project last month at Simul Grand Rounds. Those of you who have access to the Grand Rounds site might want to tune in and see if you can get the recording if you didn't happen to attend. Alex received his PhD from UC Berkeley in 2019, and already by that time, he had done some undergraduate research at Princeton and published a book based on that called Freegans, Diving into the Wealth of Food Waste in America. And that book is available from the University of Minnesota Press. His talk today draws on his research for the first book, Mental States, and is entitled Bounding and Scaling, Allocating Psychiatric Care in France and the United States. Alex, it's over to you.
Great. Well, thank you very, very much for the invitation to be here. I'm so grateful for it. 1 second, I'm going to set up the screen share, and hopefully this will work. Okay, so hopefully folks can now see my slides and not my notes. But if that's not the case, now would be a great time to tell me. So thank you very much for that kind introduction. That was a great sort of overview of where my work is right now. I have sort of recently a lot of my my focus and my presentations have been on this book on conservatorship in California. It feels like a very timely topic right now, and that book is heading off for publication, hopefully to come out sometime in 2023. But I'm really excited to be here because I haven't, recently had a lot of opportunities to talk about my older research, which is this comparative project looking at the trajectories of people living with severe mental illnesses in France and the US and their trajectories between different institutions. So I'm very excited to share with you some of this work today, even though it's probably a little less developed and a little more preliminary than my work on conservatorship. So my talk today is about the micro-level decisions by clinicians about whether to provide mental health treatment, how much treatment to provide, and when to withdraw it. This decision, as I conceptualize it, and certainly not just me, but as we sort of think about it in general in the social sciences, is structured by three competing pressures coming from outside the clinic. On one hand, mental health systems face an expanding demand for care. Scholars like Peter Conrad have characterized this as reflective of broader social process of medicalization, by which a greater range of psychological states are classified either by professionals or individuals themselves as problematic and amenable to treatment. At the same time, mental health systems face pressure around cost. Scholars like Roy Livne or Armando Lara-Malan have emphasized the fiscal pressures that we might call rationalization, a demand that care is allocated in ways that comply with increasingly strict regulations and survive cost-benefit examination. Although those previous two forces are endemic to medical systems more broadly, mental health care, and particularly safety net mental health care, faces a third demand, which is to provide social control. Researchers like Josh Syme, Helena Hansen, or Neil Gong have in various ways shown the pressure for medicine to act as a kind of poverty governance, managing disorder and disciplining the poor. But how do mental health systems and clinical teams balance these cross pressures? What I want to show today is that the disparate responses to competing demands around cost, care, and control in France and the United States are structured by distinctive underlying logics of allocation. So what do I mean by a logic of allocation? So previous work has emphasized how clinicians classify clients as deserving of care based on their moral values or professional ethos. Logics of allocation is kind of taking one step further backward to look at the kind of unstated assumptions that clinicians have about what it is they're actually trying to classify and what kind of techniques are appropriate for classifying it. So my conception here is rooted in work on classification by scholars like Pierre Bourdieu, Omer, and Fourcade, but frankly, this part of the work is still a little bit of a jumble. And what I want to focus on today is instead my empirical findings about what I think these two logics look like in France and the United States. So as I'm going to show, the mental health care system that developed in the 1960s in France institutionalized a logic of bounding. Policies and regulations largely assumed that the object of the mental health system would be a discrete and distinctive group of people. As I'll show, this assumption translates into a set of practices that focuses on using professional common sense and discretion to maximize the amount of scarce resources given to real malades or sick people. The semantic distinction here is important but difficult to translate. In French, malade is a noun, not a modifier. Mental illness can be linguistically not just an attribute, but a type of person. In the United States, public mental health is organized around a principle of what I call scaling. The underlying assumption, as shown in this image from the New York Office of Mental Health, is that all people exist on a continuum between mental health and illness. On the ground, professional practices center on the problem of calibration, delivering the right amount of care to the right people at the right moment, and nothing more than that. Professionals engage in a rationalized allocation of care by focusing on readily observable behaviors that can be quantified and ranked. So my talk is going to proceed as follows. I'm going to start with some background about the mental health system in the two countries, tell you a bit about my methodology, and talk about the logic of bounding in France and scaling in the US. For each, I'm going to show you how these logics are embedded in the historical development of the mental health system and in everyday practice, which I'll illustrate through observational data from a clinic in each country. I'll then have some time to talk about my conclusions, implications, and limitations. An observer looking at the French and American public mental health systems in the 1960s might be struck by their similar predicament. Both were home to some of the largest asylums in the world. In France, their legitimacy had collapsed when 1/3 of their residents starved in World War II. In the US, repeated exposés had turned state hospitals into the shame of the states. Both countries embraced deinstitutionalization based on a common confidence that the mentally ill could return to productive lives through early community care. Deinstitutionalization was pushed forward by the parallel development of public insurance and disability income in both countries. Yet, as you can see, the trajectories diverged substantially. Asylum-style hospitals like Saint-Anne's in the heart of Paris maintain the image of the mental hospital as a place of long-term care and social segregation. In the US, deinstitutionalization was much faster and more profound. The country has now only 1/3 as many hospital beds per capita, and institutions like Stockton State Hospital, like half of state hospitals in California, are now closed. On face value, France has a much more robust and well-resourced mental health system. The country has nearly 3 times as many beds per capita, and as a result, the average stay in a psychiatric hospital is about 28 days versus 7 in the US. The country has also about 50% more psychiatrists per capita. As you will see, psychiatrists in France continue to play a dominating leadership role in the public mental health system with a more clearly hierarchical relationship to nurses and social workers. Although the US spends much more on health overall, a larger proportion of healthcare spending in France, 14% versus 6%, is allocated to mental health. This is not necessarily an apples to apples comparison, and that 14% includes a lot of things like benzodiazepines prescribed to people who don't necessarily have an identified mental illness. Finally, even though France, like the United States, has a large private sector, the specifically public part of the system serves a larger proportion of the population. So there's clearly no basis for sort of saying structurally these two systems that I'm looking at are equivalent, except that professionals in both of them perceive the same set of pressures. That is, unmet demand for care, austerity and managerial pressures, and rising rates of forced treatment. That is, demands for care, control, and costs. So the bulk of the data for this presentation is going to come from observations of weekly triage meetings in an outpatient clinic in each country where a multidisciplinary team discussed new clients and allocated them to specific levels of care. In France, the Centre médico-psychologique that I studied was the primary public provider for an arrondissement of Paris of about 120,000 people. The clinic in California served a similar role for an area that was also relatively wealthy and well-educated, but with significant pockets of precarity. In France, the discussions I observed covered the intake of 260 new patients, 79 of which were seen on an emergency basis, and 50 who were discussed at nurses and social workers meetings. I contextualized these observations with 186 qualitative interviews with clinicians and policymakers. In California, the clinic received fewer new cases, a sign of its much more restricted public mental health system. I observed 71 initial intakes, 64 discussions of closures or changes to level of care for existing clients, and 118 status updates about difficult or challenging clients. I also conducted 258 qualitative interviews throughout the state, although most of them are for the other project I'm doing on conservatorship. So my analysis here is focusing on about 25 outpatient clinicians that I interviewed. I'm going to draw some other sources, including archives, observations in other settings like social service providers and courts, a database of 1,500 newspaper articles on the history of mental health care in the two places, and the fantastic oral history project on California's mental health system gathered here at the center and stored at UCLA. Again, well, the missions of these two clinics as kind of the primary public provider for a given catchment area was similar. The populations they treated most definitely were not, and that's part of the thing I'm trying to explain today. So most notably, the people served by the CMP in France were younger, and perhaps most striking is the inverse gender distribution. So in the US, new patients were mostly male, and in France, they were mostly women. I'll come back to trying to explain that during the talk. In the US, as you can see, the clinic served a population that was far more racially diverse than the city in which it was based, with a particularly strong overrepresentation of African Americans. Making a sort of comparison to France here is complicated because the French government forbids the collection of racial statistics, and I got into some somewhat interesting interchanges with my informants at the clinic about my interest in sort of the racial composition of their clients. However, based on the nurses' presentations, I could identify which patients were foreign-born, and you can see that about 28% of people were born outside of France, and the largest proportion of those individuals were North African or Arab. So I'm going to start by talking about this logic of bounding in France. So hints of this sort of divergent logics were visible from the founding moments of each country's modern mental health system. So if that mythical moment in the US was Kennedy's 1963 special message to Congress, in France, it was a 1960 administrative circulaire that inaugurated a policy of sectorization. As in the US, France framed mental illness as a widespread but under-addressed problem, noting at this moment the role of mental illness among the social scourges appears every day more worrisome. It also emphasized the need for early intervention, declaring that a goal is to begin care for the mentally ill early with a greater chance of success and to bring to existing ill support that reduces the risk of recidivism. As such, it asserted a need to move away from institutionalization. So just as Kennedy said, reliance on the cold mercy of custodial isolation will be supplanted by the open warmth of community concern and capability, the French circulaire said that we should not lose sight that the majority of the mentally ill pose medical social problems that are not fixed by hospitalization. Nonetheless, the text also included a framing that would be the basis for a radically different conception of who the system was actually supposed to serve. So as the excerpt shows, under this policy of sectorization, the country would be divided into catchment areas of around 60 or 70,000 people. In each of these sectors, the same medical social team would assure, and this is key, for all the malades, women and men, the indispensable continuity between screening, treatment without hospitalization when possible, hospitalization, and surveillance after discharge. Although the Ministry of Health has always formally said that the sectors have to take everyone requesting care as a public service, the public psychiatrists behind the reform understood their role differently. As Georges Domaison, one of the lions of post-war psychiatric reform in France, said, the sector as I wanted it was something that could take on not the mental health of a zone, this seems like a sociological perspective that is foreign to me, but the malades of a zone. So the sector was organized around the idea of providing total care for a relatively bounded group of individuals that was estimated at between 1% and 2% of the population. Unlike in the US, sectors would consist both of outpatient clinics and psychiatric units in the old asylums as part of a single organization. Ideally, doctors would serve the same patients both in and outside the hospital. And each sector would have a global budget that they could divide between different kinds of services, but which crucially would not expand with a rising population. So how has that initial structure shaped how public psychiatry engages with sort of the challenges around cost, care, and control today? Both the sense of vocation among public psychiatrists, who still spent half of their time working in hospitals, as well as an awareness of the limits of their budgets, created significant hostility towards growing pressure from some state agencies or civil society groups for the sectors to not just address malades, but mental health more broadly. So for example, in 2008, the French Public Health Agency ran a campaign promoting primary care screening of depression. As the text you see indicates, the agency was cautious to say that the depressed state is characterized by a profound change, a veritable rupture compared to normal functioning, which is accompanied by a permanent moral suffering. Public psychiatrists, however, engaged in what one public health official called a frontal attack. They argued that the campaign was playing into the hands of pharmaceutical companies and medicalizing ordinary sadness. They even insisted that the 2011 French National Plan for Psychiatry and Mental Health declares one of its goals a fight against excessive medicalization of poor well-being, noting that this consumption of resources from psychiatry can harm access for persons with proven mental troubles. Proposals to increase early life screening for autism have provoked similar hostility. In a sense, clinicians in France were acting based on what social scientists would call a theory of performativity, the notion that labeling people as mentally ill risks creating more clients for a mental health system that is already busy with real malades. Nonetheless, the number of people requesting care from the sectors has risen steadily. As you can see, the proportion of adults being served by the public mental health system has increased from a little under 2% in 1990 to 3.5% by 2017. Professionals attributed this both to destigmatization and an increasingly precarious society. The discipline has also faced increasing calls to act as a tool of social control. So in 2008, then President Nicolas Sarkozy gave a speech inside a psychiatric hospital, calling on psychiatry to play a greater role in submitting the potentially dangerous sick to special surveillance. You can see how excited the medical personnel behind him are, as according to one article, Sarkozy confuses health and repression. At the same time, however, the available resources for public psychiatry have been largely static. Recent years have seen hunger strikes and walkouts in public psychiatric hospitals throughout the country. One Le Monde article in 2018 described psychiatry as a discipline in great suffering. Another described the sectors as at the edge of exploding. Professionals largely perceive these factors, demands for more care and control at less cost, as a threat to their core mission. As one psychiatrist lamented to me, there's a destigmatization, people are less afraid of going to see the psy, and society is really not doing well. So we have an augmentation of people who come for their malaises and burnouts. And is that part of our mission? If we accept this surge, what will happen to our schizophrenics? Crucially, although the macro level context in France essentially forces clinics to ration care, the ministry provides almost no guidance about how to do so, instead reiterating that as a public service, the sectors are supposed to serve everyone. On the ground, clinicians made quick decisions based on qualitative judgments about who constituted a really sick person. Consider the following case presented by a nurse, and it was nurses who handled intakes at the sector. So this is a woman who's 34 years old, sent by a private psychiatrist who followed her for addiction to alcohol and medication. She's 8 months pregnant. She's experienced sexual and psychological mistreatment during childhood and is declaring images of violence towards her daughter. She stopped eating for 15 days. The head nurse cuts in immediately, sort of cuts off the presentation and says she needs to be seen by the head psychiatrist like yesterday. The psychiatrist said, yes, we should plan a hospitalization. We're talking about infanticide here. The nurse says, yes, this is an emergency. We'll check on a bed. The secretary notes that the head psychiatrist has an opening the next week, and the psychiatrist says, you'll have to take someone out of her schedule, get her in faster. The nurse at this point is a little bit skeptical and says, if you look at what I wrote, it's not so urgent. There's nothing about suicide, no history of attempts. And the psychiatrist says, no way, she's having deliria about killing her child. The head nurse concludes this is going to take 2 to 3 months to stabilize. If she gives birth in the hospital, that's just how it is. In moments like these, the sector took a kitchen sink approach to bringing someone into care, dispatching nurses to their house, social workers to check in on benefits, and inpatient colleagues to prepare a multi-month hospitalization. In interviews, most psychiatrists in the sector understood their core clients as people with psychosis. Indeed, the team immediately took on such cases without any attempt to refine their diagnosis or dig further into their situation. When I looked at the intakes that provoked more debate and discussion, however, I identified that isolation, fragility, and vulnerability came to the fore as arguments for more care, as in the following case. The nurse says this is a 27-year-old woman who is coming out of a 1-month hospitalization in a separate hospital for addiction. Before the hospitalization, she was at 3 bottles of wine and 2 joints per day. I met her in the inpatient ward. She presents as depressed and withdrawn. She's also been reporting hearing whispering. She's in debt 10,000 euros, and she has a fragile personality, +++. The psychiatrist says, yes, definitely give her a quick appointment. We need to explore. Dig into the social dimension. How about this doctor? And the secretary says, she only has an opening in 2 months. The psychiatrist says, wow, we're really overwhelmed. What's the first place we have? And the doc says, we have a doctor available in 3 weeks. And the psychiatrist concludes, okay, that's it. Make sure it's a good 45 minutes and get in touch with the municipality. There might be an eviction procedure against her. We need to guard her. Note the language of the psychiatrist about guarding the woman. Cases like these actualize the idea that the sector is a kind of total institution in the community, providing for the whole social and medical needs of a bounded group of people who other institutions, like in this case, a hospital for addiction, would inevitably fail. Yet in addition to patients consulting for psychotic illness or extreme situations of vulnerability, the clinic also faced many, many, many more patients who were reporting troubles with mood, sleep, or anxiety as a result of family, social, or employment difficulties. The nurses clued in psychiatrists that these people were not coming for what they would call illnesses, but instead psychic troubles, by indicating that patients were looking not for care, but rather support, aid, advice, or to talk. In general, psychiatrists justified minimizing care to this group based on a claim that their problems were psychological, not psychiatric. They continued a distinction, now largely effaced from the American Diagnostic and Statistics Manual, that sharply distinguished depression that was a reaction to external events, a trouble, from a real malady. I was in France in November 2015 when terrorists killed 130 people in a Parisian theater and in the streets. A few months later, I was sitting in the break room at the CMP and saw on the table a short questionnaire provided by the Regional Health Authority for evaluating psychic suffering related to the attacks. Next to it was a memo from the administration at the hospital, noting that CMPs should treat responding to the attacks as part of their mission. Yet how the team actually responded when somebody came presenting with these kind of concerns really surprised me. So the nurse talks about a woman aged 43 who called this weekend to demand a consultation. She was in the pit at the Bataclan and was injured by a bullet to her shoulder. She was hospitalized for 10 days. To my surprise, the head nurse said, she can wait, she just needs time. These kind of distinctions didn't apply to everyone equally. For example, I observed the frequent assumption that North African women who claimed depression and anxiety were essentially experiencing the psychological consequences of what the white French-born CMP staff perceived as an oppressive culture. Their reactional troubles were not real illnesses. Now, there was no formal procedure at the CMP to actually refuse care for these individuals. Technically, everyone coming to the CMP needs to see a doctor. Yet there were informal practices of triage, like assigning people to an intern, a resident, giving a long wait with the assumption individuals would not come, or referring people out to private psychiatry, even knowing that private psychiatrists were not taking new clients. France is, of course, the birthplace of Michel Foucault and sort of associated with many critiques of the imbrication of psychiatry and policing, as this flyer from the 1960s that is denouncing the psychiatric police sort of indicates. In practice, though, the professionals in the sector were ambivalent about the relationship between care and control. On one hand, they readily used involuntary hospitalization for patients they saw as true malades. Half of the sector's beds were occupied by involuntary patients. On the other hand, they were highly resistant to people whose problems they saw as primarily about personality problems, addiction, without attendant mental illness, social needs, or criminal justice contact. For example, judges in France are imposing more and more frequently obligation de soins, or obligation for care, as a condition of probation. But that probably overstates the actual obligation that entails. So here's a man coming in at age 22 and they're diagnosed, they're characterizing the case as someone with alcohol use. The nurse says he's coming in the context of an obligation for care from a judge after driving a car under the influence of drugs and alcohol. The head psychiatrist said, so why didn't this go to an addiction doctor? The nurse says, to be clear, he has no demand here. He's coming because he has to. The head psychiatrist says, it doesn't even sound like this is pathological. And the head nurse concludes, have an intern sign off on the paper and get rid of him. Depending on what typology somebody fell into, the rules of allocating care were different. For example, people whose problems were deemed as not psychiatric were dismissed sometimes for lacking clear demand for care, as in the case of this individual. However, many real malades had no demand for care, which was never seen as a barrier to serving them. This logic of bounding seemed both intuitive and inevitable to French clinicians. Guarding resources for real malades made sense. A real malade was not likely to stop being a malade, so care needed to be permanent. What you see is a flow chart for the evaluation of new patients from a guide for clinics. It has no endpoint. There's no sort of discussion of when somebody would leave the CMP's care. As one psychiatrist proudly told me, we never stop following someone. We tell them treatment for life, not just for care, but we accompany you towards rehabilitation and recovery. And everything is paid for 100%. In reality, though, the standard level of care for stabilized malades, a monthly visit and injection, occasional visits from nurses, and help from social workers in maintaining disability benefits and public housing, was not enough to keep many individuals engaged. Instead, many patients floated in and out of sector care with their files never really closed and then quickly reassigned after they reappeared, frequently through hospitalization. Meanwhile, these informal triage practices were not really enough to prevent the ongoing expansion of sector caseloads, leaving professionals feeling overwhelmed. Nonetheless, what's striking is that outside of the consultants working in the Ministry of Health, almost no one could imagine the alternative that I'm about to describe in the US. the rationalized calibration of care organized around quantitative criteria and constant flows of patients between levels of treatment, a logic of allocation that I'm calling scaling. One second. So the expansion of publicly funded outpatient care in California started around the same time as in France. The 1955 Short-Doyle Act provided matching state funds for county programs providing outpatient and inpatient care, information, education, and consultation services. Unlike in France, though, the act was almost always presented in conjunction with claims that a much larger proportion of the population needed mental health treatment than was receiving it. For example, in the excerpt, you can see in 1957, the director of community services at the State Department of Mental Hygiene reported that while there has been no thorough survey in California of the number of people needing such services, mental health care, demand was tremendous. She extrapolated from a survey by one parent-teacher association in the Central Valley to estimate that 10% of the population, or 1.3 million Californians, required treatment. Ironically, the much greater potential reach of mental health was clearly identified by opponents of it. So at one 1958 meeting to approve a clinic in LA, the Committee for the Preservation of the Constitution of California, the League of Christian Parents, Daughters of the American Colonists, and American Crusaders Against Communism argued that mental health programs were a method of brainwashing citizens into recognition of the necessity of world citizenship. And I'll have to note that I find this amusing because at this point, many psychiatrists in France were literal members of the Communist Party. But in this case, here we have sort of claims that mental health is this communist plot that affects everyone. Short-Doyle programs, unlike the sectors, assumed that intervening in people with low-grade troubles would prevent them from getting worse, as a conceptualization of mental health as being on a continuum would suggest. So one psychiatrist involved in some of the prevention programs created by the Act said, we'd go to the schools, work with teachers and various staff, really try and alert them to the signs of emerging mental illness. The idea being that would prevent or keep things from getting worse. Yet the ambitious scaling up of mental health services in California has always been shadowed by austerity that requires them to be forcefully scaled back down. The Short-Doyle Act was expanded in 1967 with the Lanterman-Petrus Short Act, which also limited involuntary treatment. It upped the state match to 90% of local programs' costs. As you can see, Reagan initially took the money that had been going to state hospitals and reinvested it in the community, but cuts in the early 70s meant that LA was already talking about cutting its Short-Doyle population by 1/3. In 1978, Governor Brown, in response to catastrophic conditions in state hospitals, promised a year of mental health. But as soon as Prop 13 passed, Governor Brown withdrew his promised funding increase. The early 1980s were particularly cruel. Governor Deukmejian cut 1/3 of state mental health funding, and LA had to close 30 clinics in response. By the end of the 1980s, cuts in San Diego were so bad that county supervisors threatened to simply close up shop. I'm not interested in running a county mental health system without adequate funding, one supervisor sniped. In 1990, legislators came up with a solution, realignment, which was intended to stabilize funding. It would provide a dedicated revenue stream for mental health services. The target population of mental health services was clearly defined as persons experiencing severe and disabling mental illnesses, which was defined not just in terms of diagnosis, but functional impairment. And services were to be provided to the extent resources were available. In some ways, you could imagine that realignment would push county mental health programs to serve a bounded group of severely impaired adults, much like the sectors. Yet such an approach is always unstable in the US, where entrepreneurial actors provide constant evidence of unmet need. In 2003, advocates in California launched a ballot initiative called Prop 63, which would place a 1% tax on millionaires. Campaign literature justified MHSA by noting a general treatment gap, claiming that there were 600,000 people with SMI in the state and only 380,000 were getting care, and leveraging the widespread perception of people with untreated mental illness in prisons, jails, and shelters. The initiative, which passed 53 to 47, would scale up care in two ways. First, full service partnerships would be sort of very intensive treatment teams with a mandate to do whatever it takes to reach underserved individuals and flow them downward to less expensive treatment. Prevention and early education would then spread out care to a non-mentally ill population. The head of the Los Angeles Department of Mental Health explained in an oral history with Marcia Meldrum, thank you, in the long run, the FSBs will be overwhelmed by need unless we could do something to slow down the stream of people who need those intensive services. So we need to use these early intervention strategies to slow down the stream of people being disabled by mental illness. Notably, MHSA was not supposed to refund core county mental health services. And when the recession came in 2007 to 2009, the public mental health system's client population dropped from 650,000 to 450,000 and has only managed to rebound to its previous levels recently. Now I'm going to pivot to talking about how this plays out at the micro level. So there, in the clinic I observed, professionals had to manage the paradox of a system that actively outreaches to push people into services, but then expects clinicians to rapidly dial down the intensity of services as soon as people stabilize. So the allocation of care in the California clinic, in stark contrast to in France, followed precise criteria that assign clients to gradated levels of care, as you can see in the image. Professionals largely endorsed this constraint on their medical judgment. Noted the clinic director, "As we know, when we say that we use discretion, it creates inequity. We serve the clients we like, and we make the ones we don't leave." Moreover, you can see that rather than using kind of squishy medical criteria like symptom severity, assignment was based on more readily quantifiable indicators like the number of hospitalizations or the frequency of ER contacts. So the chart on the left shows my analysis sort of based on these clinical discussions of intakes of what arguments were used by clinicians to justify increasing somebody's level of care between these very structured levels of care available at the clinic. Kind of contrary to the nightmare of Michel Foucault, danger to others in criminal justice context were not actually usually a good reason to justify giving somebody intensive services, nor necessarily was symptom severity, suicidality, or trauma. Instead, the arguments deployed by clinicians largely followed a logic whereby high-quality outpatient services were used to reduce the strain on the system caused by clients who were going too frequently to the hospital, causing disruption on the street, or who are incapable of managing other social services. So this combination of rigid non-clinical criteria could lead to complicated outcomes, like limiting care to clients who were in sharp decline and actually wanted treatment, as in the case of a 61-year-old man with schizophrenia. So here the clinic director says, "The problem is that he doesn't meet our criteria based on his current usage of the system and the fact that he actually wants treatment. So he doesn't have enough hospitalizations to qualify for care." The intake social worker says, "Yes, but it's escalating. He had a very violent 5150. That's a short-term involuntary hospitalization." The psychiatrist proposes, "Well, could we take him based on our safety criterion?" And the clinic director says, "Okay, we can take him, but if he keeps complying, we'll have to step him down soon." One of the most striking things that clinicians themselves claimed in interviews was that their work seemed less and less to be geared towards treating mental illness and less focused on addressing medical needs. So as you can see from the chart, dual diagnosis was the rule, not the exception among the clinic's clients. In an interview, the clinic director told me, "You can diagnose anyone with a disorder, but the schizophrenics and bipolars are not getting referred. It's substance abuse, characterological issues, homelessness, and medical problems." Even though the clinic services were technically voluntary, people were mostly asking for care because they wanted access to benefits or housing rather than medication. The shifting of the clinic's responsibilities towards addressing problematic behaviors was visible in the case of a white woman diagnosed with somatic symptom disorder because of a false belief her child had whooping cough. She had recently shut down a city council meeting after the city towed the RV where she was living. The clinic director says, "We have pressure from the city manager to do a full court press here." The psychiatrist says, "So why is this FSP their highest level of care?" And the clinic director says, "Because of the number of contacts with emergency services." A case manager cuts in to say, "Wait, what is somatic symptom disorder?" And the FSP director sort of continues his skepticism and says, "This is somebody who made it 40 years without being in the system. There are risk factors here in terms of homelessness in a kid, but it's not a classic presentation." The clinic director sort of sums up and says, "I agree, but the times are a-changing. The system is more inclusive and we have more and more non-typical people." Later, the clinical team debated what approach to take with the woman. The FSP director interrogated the crisis clinician who had seen her, asking, "What is her understanding of what's actually going to happen with the treatment team? Does she even want meds?" The psychologist replied, "Well, she believes she has some kind of neurological condition and also anxiety. She might be open to medication, but whatever we prescribe needs to be aligned with her beliefs about her medical needs." The whole discussion emphasized finding a strategy that would address her problematic behaviors and excessive use of crisis services, largely independent of intervening in her subjectivity or cultivating insight. By contrast, for French clinicians, getting people to self-identify as malade was a core goal. While allocating care based on quantitative criteria like service use in order to reduce excessive service use was largely consensual, there are moments where the ways in which this approach created apparent indifference to subjective suffering created tension and demanded exceptions. So here's an intake for a woman, an African-American woman diagnosed with depression and post-traumatic stress disorder. The intake social worker comments, yeah, it's very tough to decide if she qualifies. The team head notes, yeah, she was homeless for 27 years, but now she's actually housed. And intake goes on. If you can believe it, she has a bachelor's degree and was working, but she lost her job and her insurance. And if you look at her, she's cut her arms from here to here. The clinic manager notes, so to be clear, there haven't been any hospitalizations, just 2 visits to the ER. That's important for us. And she's already getting meds. Intake notes, yes, but look at this history. There's a crazy history of abuse. She could really benefit from a strong relationship with a therapist and a bit of case management. It's true she's been savvy and stayed out of the hospital. She even said to me, that place, the hospital is disgusting. I pay my bills, you can't 5150 me. The team head notes, I'm seeing from the intake that there are multiple rapes and suicide attempts. The clinic manager concludes, well, she doesn't really meet our criteria. There's no hospitalization and she's not homeless. But we know that we underserve women and people with trauma tend to underreport their symptoms. So given that, I'm okay with serving her. We'll focus on the clinical dimension here. She has trauma and the idea is to develop a therapeutic relationship. We need to focus on that rather than trying to get her to do stuff in terms of case management. So you can see that the clinic director recognized that the clinic was disproportionately serving men, and that this was driven by the prioritization of disruptive behaviors over things like trauma or sort of suicidality. Nonetheless, as you saw from the early data, these exceptions remained exceptions, and the sort of clinic continued to constitute its population largely based on scaling up treatment based on these behavioral criteria. Once somebody was assigned at the CMP in France, their care was largely determined by their psychiatrist. At the clinic, however, meetings involved an active discussion of how to bump clients up and down between multiple clinical teams based on their current status. Someone at risk of losing housing, for example, could be smoothly increased to a new level of care. After resolving a crisis, the expectation was that in a rationalized system, treatment would be scaled down to make room to medicalize others. Paradoxically, doing so often meant redefining goals in non-medical terms, akin to what sociologist Neil Gong calls tolerant containment. So the following case was considered a success, even though the individual was sort of not actually accepting any mental health treatment. So the case manager notes, this is a client who's homeless in a tent. Now she's in supported housing. She gets along with her building manager, a bit less so with the other tenants, but it's okay. She still has delusions and hears voices all the time, but she adamantly does not want medication. She needs to stay with us to keep her housing voucher. The intake social worker comments, I remember her. She was really lovely until she talked about stabbing people in the eye. And the case manager sort of cuts him off and says, look, she has not been violent. And the clinic director concludes, well, good work. Let's move her down to a lower level of care, the lowest level clinical team in the clinic. Yet the stated goal of helping clients achieve true independence was never reached. The clinic maintained the image of a fluid continuum by closing case files when individuals refused treatment or disappeared for more than a month. An open file is not treatment, the clinic director frequently stated. Yet nearly a third of intakes were for individuals who had previously been served by the clinic and had their files closed. In effect, linear flow through the continuum was actually people swirling in an endless eddy. Okay, so now some conclusions. So my argument today has been that clinics in the US and France respond to competing pressures around costs, care, and control by falling back on shared common sense but unstated logics of what mental illness is, how classification should take place, and what the result of classification should be. So in France, clinicians approach mentally ill persons as a small bounded group, categorically distinctive from those with psychic troubles and those whose problems are not psychiatric at all. Both policy and practice in California, on the other hand, is organized around a continuum on which everyone's mental health fluctuates. On the ground, clinicians in France make judgments based on typologies of persons that are seen as fixed. By contrast, we saw how in the clinic in California, external scales of behavior and service use were used to calibrate treatment to titrate care up and down. These have two broader effects on who winds up getting served. In France, clinicians resist rationalization. That is, they claim that care can't be sort of wound down or more carefully calibrated. And that necessitates that they resist medicalization. That is, pressure to serve or control more people. In the US, the embrace of an ever-expanding role for the mental health system effectively also obligates rationalization. That is, the constant dialing down of care to make way for new clients. The result is two mirrored sets of exclusions. The French system excludes people who are disruptive but don't fit clinicians' conceptions of a deserving sick person. In the US, frequently, people who did not seem obviously ill were served because their behavior was disruptive. I want to briefly comment on how this fits into my overall book project. So I'm ultimately interested in how different organizations of the mental health system constitute different populations of people as severely mentally ill, and how the way these populations wind up being constituted poses unique problems the system has to respond to. On one level, it would be easy to juxtapose a US system that has moved towards greater community care with a French one that continues to rely on institutional psychiatry. But other scholars like Isabel Pereira, with whom I've collaborated a few times, have called into question this distinction. As you can see from the graph, actually, there's no inverse correlation between inpatient and outpatient services. Countries that provide more of one tend to provide more of the other. Instead, my work sort of focuses on the idea of a division between systems that, like France, maintain paternalist control based on a dominant categorization of people as mentally ill and deliver an extensive range of services to people under the guise of the health system, and a US system in which services are fragmented, partly because simply calling somebody mentally ill doesn't unlock a lot of services. And instead, people have to be categorized in terms of a range of other sort of state-recognized categories, like being disabled, a criminal, or a substance user. Okay, by way of some limitations, and there are many. So first, I've been talking about the US and the French mental health systems, but I want to now at the end sort of emphasize how flawed this is as a shorthand. So there are real questions about how generalizable my observations are. Are these local idiosyncrasies, or are these state patterns or national patterns? With these kind of logics of allocation, would we see them if we looked at the private mental health system in each country? That said, while I think this is an important limitation, the hundreds of interviews I've conducted and observations across multiple different sites. So remember, I also observed social service offices and courts in New York and California, makes me think that I am actually capturing some real national level differences here. A second important limitation of this part of my research is that there's no inclusion of client perspectives or client professional interactions here. I'm not analyzing whether clients understand their own conditions in ways that comport with these logics of allocation. And finally, I'm aware that there are some apparent counterexamples to my claims about these two different logics. So for example, in my research on conservatorship, I found some examples of what we might call bounding, whereby conservatorship programs exclude substance users from conservatorship. So this logic of scaling maybe doesn't show up in every single institution in the mental health system. That said, I want to sort of close with a few theoretical implications. So first is that in the social sciences, the framework of medicalization has placed a huge weight on the expansion and use of formal diagnostic categories. There's almost a cottage industry of books that critique the Diagnostic and Statistics Manual. And it's based on the assumption, as Robert Castell claimed, that the diagnosis determines the institutional fate. But what I saw in my observations was that sort of diagnosis was actually, part of decision-making, but it wasn't determinative in it at all. Instead, in France, the question of kind of what type of a person are you was central, whereas in the US, the question was more, what are your behaviors? What is your impairment? Second, this focus on logics of allocation calls attention to the very different ways that clinicians understand the purpose of classification in allocating care. So in effect, French clinicians saw classification as performative. They saw labeling as a powerful tool that could both create illness and also, as a result, create a misallocation of resources. In California, clinicians treated classification as at least hypothetically or potentially objective. It was a necessary and sort of potentially accurate way to extend the system to people in need. Finally, while some of this discussion of logics of allocation is very abstract, what I want to sort of leave and emphasize is that these logics in each case kind of exclude certain kinds of suffering or distress from the mental health system's purview. The power of these logics is that they make those exclusions largely seem inevitable and logical in a sense. The value of comparative research, in my view, of juxtaposing the French and American systems against each other, is that they render those exclusions visible and point to alternative population possibilities. And on that note, I'll express my gratitude for your time and your attention and ask if there's any questions or comments. And in case you're curious, a few of my published works are listed below. Thank you very much.
Thank you, Alex. That was really fascinating.
I'll imagine that it's very odd to sort of finish and have complete silence. But I see. That was not a desperate plea for clapping, but now it has come off as a desperate plea for clapping. So I appreciate your response to that sort of pathetic.
Well, there are a lot of clapping hands.
Yeah. Now I'm seeing a lot of them. Okay, I'm gonna shut up and hope that there are some questions.
So yes, we're open for questions. I don't really have any questions in the chat, You can put a question in the chat, or you can raise your, Ippy, you have your hand up, right?
Yeah, I do. Thanks, Alex, for another great presentation, in addition to the one you gave in Psychiatric Grand Rounds a few weeks ago. I'm curious what the role of the broader social welfare system and existence or lack thereof of a social safety net has on the way these psychiatric teams operate. I have an intimate familiarity with the American mental health care system, much less so with France. I sort of idealize a social welfare system that exists in France that doesn't here, but I don't know if that's true, because I wonder the American story of sort of caring for someone because of their behavior and their vulnerability, despite them not really having a diagnosis. I wonder if that happens because of an awareness that this is where most of the public benefits exist in the US, right? Where we've cut a lot of the social welfare benefits for sort of adults, so we've kind of trained a lot of people to sort of seek benefits, through the mental health system, and they know what to say to get them. Right. So you could call it biological citizenship or, so anyways, so I'm just curious how that broader context determines or influences the way the teams operate.
Yeah, I think that's absolutely crucial. And, sort of you can't escape the fact that it's not just the medical systems that are very different, but the whole social systems that are different. I'll say that, when I have a lot of these conversations, I feel that I always kind of have to say, I think that the French social safety net is probably worse than most Americans think it is. And the American social safety net is actually probably better than most French people think it is. So the existence of Medicaid, they have no idea that there's actually any health insurance, public health insurance for the poor. They sort of, and the French social safety net is fraying in a lot of ways, but it certainly is more robust. And for example, the existence of just widespread public housing in Paris is an incredibly important sort of feature of the psychiatric response. But one thing that is interesting is that in France, actually, these sectors have an extremely sort of strong grip on patients, and they want to control their access to benefits and their housing and their medical care. And that's a very expensive model. And the ministry has actually been pushing for kind of a separate disability system to take on a lot of addressing the social needs of these, malades in the sector system. But what's been interesting is that, and this sort of fits with my arguments about typologies, that these systems are really built around discrete types of people. And the disability system has been very resistant to taking on people who don't fit their classic clientele. And the health system has been very resistant sort of transferring responsibility. So there is a much broader sort of welfare system in France, but you can actually see some of these sort of logics playing out even within that. But that is very important. And I think, I think that is, this sort of need to medicalize all sorts of social problems because that's the only way to address them is very, very crucial in the US. I think that's an absolutely, very important point. But in some ways, what was striking to me is how much the clinicians in the US were willing to go along with that, right? That there was sort of widespread adoption of, there's a lot of people on our caseloads that we're just going to keep them because they need to keep their housing, and we know they're not going to accept treatment or ever go to therapy. And in France, there's just completely unacceptable. I mean, it would just be, we don't have clients at the CMP who don't ever accept treatment. If they're not accepting treatment, we're going to go force them to have treatment. So I think that, what you're pointing to is a really key part of the explanation. And I guess that was a very long-winded way of saying I agree with you.
Okay. Other questions? Okay, well, I have a couple. Alex, in the US, at least in California, okay, people show up in the mental health system for two reasons. Right? They're referred for two reasons. One is their families refer them. Occasionally there's self-referral, but usually it's the family who's behind their showing up. Or they become disruptive in a very public sense. They run into trouble with the police, or they create some kind of neighborhood disturbance, or they attack somebody, or something happens. So, and I'm just wondering if Francis, I couldn't get a sense from what you were talking. Clearly, disruptives are a problem. Are most of the patients there because they're disruptive, or?
No, I mean, I think there's a kind of a core in France. There's kind of a core set of patients that are, people potentially with schizophrenia that is often combined with a lot of social precarity, and those the sector tries to have a pretty tight grip on, and it is based on a sense that they're both disruptive and pathological. But then there's a huge attempt to kind of push out and not accept responsibility for a lot of other kinds of disruptive behavior that other actors in society would like the sectors to have responsibility for. So, for example, all this instance of judges that are referring people to the sector for care, and the sector is just like signing the paper and getting rid of them. Like they really don't want to take on those kind of cases where in the US there's this sort of much tighter imbrication. I'll say though, I was surprised, the clinic I studied, which really was serving a very acute population, most of the people were actually self-presenting. They were coming for an intake. I mean, they had certainly been, sent there or referred for an intake, but, they were actually sort of coming on their own 2 feet. And I think that was part of, this kind of ties to my piece of the conservatorship research, is that in the US, there's kind of a huge gap, I think, sometimes between the voluntary and the involuntary part of the system. That this clinic I studied, they defined voluntary as like, you have to come, and if you say no 3 times, we're going to close your file and we'll see you again the next time you're hospitalized. Whereas, the French actually were less for the kind of real malade. The French were sort of more, they were not going to close somebody's file just because they missed a few appointments. Actually, at some point they were going to potentially go knock on that person's door and hospitalize them. But certainly there wasn't this kind of flow in, and so I think the US has, but this is in general, because the sector in France has both the outpatient clinic and the inpatient clinic. So it's a much more sort of integrated approach. Whereas in the US, I think there's often this huge gap between the super restrictive conservatorship system and this outpatient system that I think actually uses the claim of being voluntary as a way of just kind of constantly cycling people through the system. Look, we're closing a lot of files, isn't that great? Because people are actually just saying no, and they're going to be back in a few months after their next hospitalization. It's a much more cyclical, wound up being much more sort of a cyclical churn through the system.
And
so, I'm sorry.
No, go ahead.
I just am so grateful to hear this finally, because when I first encountered you, this is the information that I wanted to hear, because I love France and I live in California for the last 50 years or so. I've worked in other state mental health systems. And so I really have been on the front lines of watching the decentralization, or not decentralization, I would say the depopulation of state hospitals and the shift from the state hospital to the community and that whole movement. And I've been a very active proponent of community psychiatry. However, I love what you had to say. I hope that I get a copy of your slides, because it is so totally true. Community psychiatry has never been fully funded, and this system that we have, I'm here in Los Angeles County, but it's bigger than Los Angeles County, of shifting people. The minute they get stabilized, oh, there you go. Now you get a whole new treatment team. Oh, you're going to graduate from this team to that team. And what do we know about people that have serious mental illness is that they don't do change, and so you take people that are already terribly fragmented with their perception of reality or whatever, and put them into this very fragmentalized system and call it a system. I don't know what clinic you saw, but I have a client right now. The mother calls me periodically. She lives with her son. Her son is dangerous to her. And his way of coping with that is just to tell her to leave. So she sleeps in the car so that she won't upset him. He won't take medication, so the local clinic closed his case because he refused medication. That's the criteria. And this guy is just a time bomb. He's going to explode one day. We all know it's going to happen. But, you know, the system that we have really does tilt towards the people that are not the traditional people with psychosis, with serious mental illness. I am really deeply, deeply concerned about the lack of focus, whether it's financial or, you know, in the budget or whatever. We're always talking about people with all of these other problems. Okay, I get that they are disruptive. People with co-occurring disorders typically are extremely disruptive to society, use up a lot of taxpayer resources. But in the process, we are forgetting people that have just basic serious mental illness and psychosis, and they need a good amount of continuity of care. And the system that we have right now, there is no continuity of care. It just does not exist on any level.
Yeah,
And just
thank you, Barbara. I think that's I think what you said here, and based on personal experience,
I see it every day.
Yeah. I don't want to cut you off, but I have 2 questions pending and we only have a few minutes.
Oh, I'm so sorry. Thank you for letting me.
Okay, Max, did you have a question? Max?
Hi, sure. Thank you. Thank you, Alex. It's great to see you. I appreciated as much as I could catch of this presentation while taking care of a newborn, but I wanted to hear a little bit more. You mentioned a bit about how difficult it was to get info on the racial dynamics within France, given that there's such resistance to tracking it there. And obviously here we know that there's a certain way that we overemphasize tracking it. So I'm curious if you could talk a little bit more about the racial politics, and especially in relation to a public system where in this country we think of the public system mostly serving the racialized poor. My sense from afar in France is that some of the reactionary far right movements have been about trying to exclude former colonial subjects who have come to France from those public systems. So I'm curious if you could talk a little bit more about how that fits in with this. And thanks again for such another great and interesting talk.
Yeah, thanks to both of you. And I just have to shout out to Barbara's been a wonderful supporter of this research for multiple years now. So thank you so much. I do think, I sort of these questions have made me want to offer a quick caveat, which is that I think a lot of what this book is highlighting is that there are really difficult trade-offs between these two systems that I think are not easily resolved. So I think in some ways the French system is much more paternalist and protective, but in a way that often can be very stifling and very limiting of people's autonomy. And in the US, you see the flip of that. So it's not, I don't feel it's not super easy for me to sort of say the French system is superior, although I think in general, the French welfare state produces vastly better outcomes. And, we should have something more like that. But I just want to also sort of say, the clinic I studied in both countries is obviously anonymous, but I have just a huge amount of respect for the professionals. And in both cases, they're working within systems. Part of this logic of allocation is the idea that, they're working within systems that really limit their freedom. So I don't want to come off as sort of dismissive at all. I think the sort of racial politics question is such an interesting one, and one that is very hard to resolve, to address, given the nature of it in France. It's very, the clinic, as I showed, was serving about 28% foreign-born, but some of the other settings I was observing in France, the presence of kind of former colonial subjects was, extraordinarily high. So, for example, I did observations in a benefits office that determines eligibility for disability, and there was a very strong kind of typology of the femme de ménage qui a trop fait le ménage. It was basically the cleaning lady who cleaned too many houses. And that was inevitably a West African woman who was applying for disability benefits with maybe not a very specific, a precise disability, but whose body was essentially used up by the incredibly hard labor of being an immigrant, a low income laboring immigrant. And actually for those individuals, I saw a lot of mostly sympathy from the kind of pretty left-wing social workers there. Another setting I looked at where I actually could see race because I was looking at evaluations of people was when I did observations in a psych ER in Paris. And there probably, I think 60% of people coming into this psych ER brought by police were North African or Black, which we don't know the racial statistics of Paris, but that's, incredibly disproportionate. And I raised it, I was sort of raised it with the head of, again, sort of a very progressive leftist, French psychiatrist, probably was a communist, in the 60s. And he said, I don't know what you're talking about. I mean, it was just a totally, I mean, it was clear that it was sort of not okay that I was in my field notes writing Black, that was really problematic. And and I think that the French would look at the racial system in the US and be like, why would we want to do anything the way you do it, right? You say it's so bad that we don't track race in France, but like, why would we want to do anything around race the way you're doing in the US? So the racial politics was very fraught. I think in California, it was frankly just sort of taken for granted that, African Americans were going to be hugely disproportionately represented. I think it was known and accepted and sort of not, it was actually not, there was not that much reflection on it because it was just sort of taken for granted. There was some more reflection on why Latinx or Asian individuals were not seeking care. I think there was more reflection on that, but certainly, it's very hard to incorporate, when you're studying France, it's very hard to talk about race, but, race looms, was part of, was present and shaping what was happening at every institution I was studying.
Okay, we're officially at the end of our time, but we do have a couple more questions and we're going to stay on. Alex, if you
I'm happy to stay on, yeah.
Okay, I have one question in the chat, which I think is really kind of important. It's often said that in the US, prisons are the de facto mental health providers. And given this situation, how does this compare to what happens in France? Did you interview any mental health providers in prison systems as part of your project?
I did in both countries, although it hasn't been as much of a core part of my research, which is more of a flaw, but also a kind of concession to the fact that you can only do so many things. What's interesting, if you talk to French psychiatrists, they're very concerned that there's tons of mentally ill people in prison in France, and sort of surveys of prisons suggest that, there are significant proportion of, significant number of prisoners in France do have diagnosis of mental illness. On the other hand, there's only 1/5 as many people relative to the population in prison in France as in the US. So even if you have a lot of people with psychosis, a large proportion of people in prison have psychosis in France, the number, it's just a much, much smaller proportion of people with psychotic illness are going to wind up in prison in France, just because their carceral state is minuscule compared to ours, even if it's, sort of substantial. But what I can say is that, again, there was a lot of these kind of bright line distinctions that there were often a lot of cases where there was kind of a division of typology and decision-making between people who are just criminals and are just acting out and have personality problems and real malads. That at this ER, that was a lot of the distinction that was happening. And so there was actually a lot of gatekeeping. There was a lot of gatekeeping of the mental health system against people with criminal justice contact that I saw in France. Obviously in California, the imbrication of these systems is just much more intensive. At the clinic I studied, they were constantly getting people who were being released from incarceration, or their clients were disappearing because they were being incarcerated. So again, there's kind of a fluidity and fragmentation of the US system between different kinds of institutions. Whereas I think in France, there was much more of an attempt to keep these separate systems separate, even if that sometimes meant, people who might have needed care were getting pushed out of the system because they're just a criminal, they're just the caracterial, it's like, they're just somebody who's just acts badly, and it's not sort of an illness. I hate to I'm kind of keep coming back to my point about this bounding and scaling, but I do actually think that, I am hoping that some version of this or some way of conceptualizing this really does capture some of the key differences between these systems.
Yeah, I think that's okay.
Thank you for that, but super important question. Thank you.
You've had your hand up for quite a while.
Oh, yes. Yes, thank you for the presentation. So I have a short question. So I wonder to what extent professions or the system, professionals and the system of profession play a role here, because based on your conversation, the conversation you posted, it seemed that in the United States, social workers really played a role, but in France, I don't see the like more intensive involvement of social workers based on your presentation. So I wonder with what their system of profession played a role here.
Yeah, so that's incredibly correct. And that psychiatrists are just in a much more dominant position in France. I think there's a couple of reasons for that. I think the fact that the hospitals are still very tied into the community mental health system, and hospitals are kind of the seat of psychiatric power. You know, you're a doctor, you work in a hospital. You know, the system is really run by psychiatrists. The ministry has a lot of psychiatrists, and the relationship to, you know, and the sort of professional relationship in the sector is there's psychiatrists, nurses are very, you know, clearly in a subservient position. I mean, not subservient, like there's a clear hierarchical relationship. The decisions are being made by psychiatrists. And then actually the role there isn't really, clinical social work is not really a thing in France in some ways, that social workers have a training in sort of, you know, kind of the social, you know, the benefits access, navigating social service systems. They generally don't have a clinical training. So the sector I studied had social workers. They were literally on a different floor, and they weren't invited to this meeting. And the doctors would sort of write commands to the social workers of what to, you know, what benefits to apply for. And then the social workers had a lot of freedom, and then, you know, they carved out their own role. And, you know, I don't want to pretend that they were sort of totally under the thumb of psychiatrists, but the psychiatrists thought they were. So it is, you know, and then in the US system, you know, psychiatry is so much withdrawn into medication management in the outpatient, you know, in the outpatient system. But I think the dominance of psychiatry sort of does maintain this more medicalized lens in France that is really defining people in terms of pathology. And sort of, you know, seeing them, you know, sort of centralizing their treatment within a medical system rather than kind of fragmented between social services. But certainly, like I think the difference you're picking up on is really important.
Okay. Thanks, Alex. Any other questions?
I have a question. Hey, Alex.
Hi.
So I want to ask you one of the things I'm getting from your talk was excellent. I'm very glad to have come. I want to ask you, it sounds like in France, there is more often the need to have sort of a negative feedback to a patient than in the United States. Like in the United States, if you're kind of like disruptive, you're going to be given services, versus if you're some sort of like happily homeless schizophrenic, you may be sort of left to your own problems. And the French system, because of its need of bounding, to use your words, requires more often telling a patient like, hey, look, you don't meet the criteria, like you're not our people, you're not the malade that we treat. I was wondering if that was one way that sort of things played out. Like in America, I think we have sometimes a hard time with sort of the disruptive person having this difficult conversation with them, which is like, oh, you don't meet for services.
Yeah, I think that it's interesting though, because I think what I was struck by in the sector is that the rules are really different depending on which box you're put into, right? So if you're somebody who has who is perceived as having troubles, like you're depressed because you're, you know, often there was this sense of like, you're depressed because, you know, it was 2015 in France, there was a lot of unemployment, like there were a lot of social problems, and you're depressed because of that. And you're behaving badly, and you're not sort of clearly engaging in care, get lost. Like, you know, we're not here to serve you. Whereas for somebody with schizophrenia, there wasn't an expectation that that person be behaving well or super engaged in care. You know, that there wasn't, you know, there was sort of there was a tolerance for, but attempt to correct disruptive behavior. I think what was different is that there was this push for people to adopt a more medicalized identity. So like when I observed, it must sound like I observed like a bunch of random things, but there was sort of strategy. But I also observed in France hearings where people who had been hospitalized involuntarily asked to be released. And a lot of the reasons people would be kept in the hospital in France were, we don't feel you've really you've really accepted enough that you're ill, right? Like you haven't really understood that you're malad and like you really need to consent to treatment in an enduring way. And that is definitely not what I saw in like hearings in California, where it was basically like, have you hit anyone recently? You know, like, are you actively suicidal? Like, can you have a semi-plausible plan for health self-care? Okay, like you're good to go. So I think that you're picking up on a dynamic that certainly applies to to a lot of the people the sector is treating, but not necessarily their kind of what they see as their core clientele that are going to be their core clients kind of regardless of how they behave in some ways. But thanks for that question. I don't know if that was a satisfying answer, but it was a good question.
Yes, very good questions.
Yeah, super great to have this. It's very exciting to have this engagement with my work. So thank you all very much.
Okay. I don't see any hands up.
Okay, and people are leaving, so it seems
Yeah,
like
and people are having to leave. Thanks very much. That was a great talk, Alex. And as you can see, I think people find it not only interesting, but relevant to what
thank
we're
you.
working with here today in California.
Well, thank you so
Thanks,
much for the
everyone,
invitation.
coming.
Thank you so much.
Okay.
And be on the lookout for our next announcement of our next presentation, which will be when, Ethel?
So there is a webinar next week for the Lancet series that we are doing with the Health Justice Seminar series. It's called Reparations. It is called Americans Health, Supreme Court v. Americans Health.
Great.
And I can send the flyer in the chat really quickly. But that is our next in terms of what's collaborating with the HETS seminar.
Okay, and email notices will be going out to everyone.
Mm-hmm.
Thank you all for joining us. Thank you again, Alex. And
Have a great day, everyone.
We're all looking forward to your book.
Don't hold your breath. It could be a while, but thank you.
Okay, very good.
Thank you.
Bye.
Goodbye.
Nope, I wasn't able to.
Okay, don't worry about it, Ethel. If you're sending an email, that should do it.
Okay, thank you.
Okay, take care, everyone. Thank you for coming.
Thanks, Marcia.